Good afternoon. Thank you for being here today. My name is Phan, and I'm honored to present my Doctor of Nursing Practice project titled Culturally Sensitive Language and Colorectal Cancer Screening in Vietnamese Americans. This project represents the culmination of my doctorate journey at Maryville University's Catherine Macaulay School of Nursing. More importantly, it addresses a health disparity that I have witnessed firsthand throughout my decade of practice as a family nurse practitioner serving the Vietnamese American community. I would like to acknowledge my DNP project committee, Dr. Carol Berger, who served as my committee chair, providing invaluable guidance throughout this process. My second reader is Dr. Jennifer Thiel from Maryville University, and my community member is Dr. Vu Chung from the Family Practice Clinic where this project was implemented. I am deeply grateful for their mentorship, expertise, and support. Let me begin by framing the problem of this project. The project aim was to evaluate the impact of culturally sensitive provider-led education on colorectal cancer screening adherence among Vietnamese American patients aged 45 to 75 in primary care. Why does this matter? Colorectal cancer is the third most common cancer and the second leading cause of cancer-related deaths in the United States, despite being highly preventable through screening. Vietnamese Americans have significantly lower screening rates at 59.5% compared to 74.4% for non-Hispanic whites. These disparities are driven by cultural beliefs about cancer, language barriers, and limited health literacy. When patients don't get screened, they present with later stage disease, worse outcomes, and preventable deaths. But here's the good news. Early detection through screening reduces mortality by 68%. And economically, every dollar spent on screening saves $2.30 in treatment costs. Research shows that culturally tailored intervention can increase screening by 15 to 20%. This project sought to demonstrate that culturally sensitive, provider-led education could close the gap for Vietnamese Americans. My literature review revealed four critical themes that supported this work. First, screening importance. The United States Preventive Service Task Force recommends screening for adults aged 45 to 75, noting that adherence can reduce mortality by 68% and prevent approximately 30,000 deaths annually. Second, racial and ethnic disparities. Vietnamese Americans consistently show lowest screening rates among Asian subgroups. Barriers include cultural stigma about cancer, fatalistic beliefs, and language difficulties. These disparities persist even when people have access to health care. Third, culturally tailored intervention work. Nguyen and colleagues in 2010 demonstrated a 20% increase in screening with culturally adapted programs. Bilingual materials and community-based approaches have proven effective across multiple studies. Fourth, provider-patient communications drive screening. Studies by O and colleagues in 2023 show that culturally sensitive communication increases trust, that providers' recommendations are strongest predictors of screening completion. Provider-led education improves screening by 18% in their research. These themes converge to support my intervention. Culturally sensitive provider-led education delivered in the patient primary care language and cultural context. To guide this intervention, I used Leninger's culture, care, diversity, and universality theory, which emphasizes the understanding culturally backgrounds is essential for providing effective and meaningful care. Leninger's proposes three modes of action and apply all three to this project. Mode 1, culture, care, preservation, and maintenance. This means retaining and supporting cultural values that promote health. For Vietnamese patients, I respected family involvement in health decisions, honor the authority of physicians, which is culturally important, and use the Vietnamese language in all educational materials. Mode 2, culture, care, accommodation, and negotiation. This involves bridging cultural beliefs with healthcare practices. I provided bilingual staff use their indirect communication styles that are more culturally appropriate for Vietnamese patients and offer flexible scheduling to accommodate work and cultural obligations. Mode 3, culture care, repatterning, and restructuring. This means gently and respectfully addressing beliefs that may discourage screening. Some patients believe screening was unnecessary without symptoms or that cancer is simply fate. Through respectfully, culturally grounded education, I reframe screening as an act of responsibility to family and emphasize how it protects family well-being, a core Vietnamese value. This framework shaped every aspect of my intervention design and ensure that I approach patients with cultural humility and respect. Now let me describe the methodology. Design methods. This was a quality improvement project used quantitative approach with retrospective chart review. I compare outcomes before and after the intervention using pre and post design. Setting. The project was conducted at a primary care clinic serving predominantly Vietnamese American population in an urban community. This is a safety net facility where I have practiced over a decade. Why these methods? I chose retrospective chart review because it allowed me to compare real-world practice patterns before and after intervention. The quantitative design provided objective, measurable outcomes. The pre-post comparison demonstrated the intervention effectiveness with the same patient population, and a quality improvement approach was ethical, practical, and sustainable in clinical practice. How did these methods answer my research question? By comparing screening completion rates before and after implementing culturally sensitive education, I could directly assess whether this intervention improved adherence in colorectal screening guidelines in Vietnamese Americans. The timeline was structured as follows. Pre-intervention data was from January to March 2025, and post-intervention data from March to June 2025. I obtained IRB approval from Maryville University and maintained HIPAA compliance throughout the project. Let me describe the sample. I review a total of 60 electronic medical records, 28 from pre-intervention period and 32 from post-intervention period. Inclusion criteria were specific. Patient had to be of Vietnamese origin or ethnicity between ages 45 and 75 due for colorectal cancer screening according to USPSTF guidelines and active patients at the participating clinic. Exclusion criteria included patients under 45 or over 75, those not of Vietnamese origin, anyone with a history of colorectal cancer, and patients who were already current with their colorectal cancer screening. Population description. This sample represents Vietnamese American adults in primary care who require colorectal cancer screening. It's typical of patient population seen in urban safety net clinics serving immigrant communities. Patients who face language barriers, cultural differences, and often limited health literacy, despite being highly motivated to maintain their health. Data analysis. For data analysis, I selected z-tests for difference between two independent proportions as primary statistical tests. Why this test? Several reasons made it appropriate. First, I had a binary outcome. Screening was either completed or not completed. Second, it was comparing two independent groups, pre-intervention versus post-intervention. Third, I was comparing proportion or percentages between groups. Fourth, I had a directional hypothesis. I expected screening adherence to increase. And finally, my sample size met the assumptions needed for normal approximations. Analysis parameters. I used a significance level of alpha equals 0.05, conducted a one-tailed test since I expected an increase, used G-power 3.1.9.2 software, and conducted power analysis, both a priori to plan the study and post hoc to understand what power I can actually achieve. Secondary analysis included descriptive statistics for sample characteristics, confidence interval calculation, effect size determination, and a G-power calculation. My outcome variable was primary colorectal cancer screening completion, either FOBT or colonoscopy, documented in the electronic medical record within the time frame. The secondary outcome was the type of screening modality patient selected. Now for the results you've been waiting for. In the pre-intervention group, the screening completion was 32.1%. That's 9 out of 28 patients who completed screening. After implementing culturally sensitive education intervention, the post-intervention screening completion rate increased to 53.1%. 17 out of 32 patients completed screening. This represents an absolute improvement of 21% points. Let me put that in perspective. This is a 65% relative increase in screening adherence. If someone had about a 1 in 3 chance of completing screening before the intervention, they now have a better than 1 in 2 chance after the intervention. This is not just a statistic. This represents real patients, real families, and real life potentially saved through early intervention. A 21% point improvement means more cancer will be caught early, more treatment will be successful, and fewer families will face the devastation of late-stage colorectal cancer. These visual helps illustrates the change. On the left, you see pre-intervention distribution. Only about 1/3 completing screening, 2/3 not completing it. On the right, post-intervention, screening completion became the majority behavior at 53.1%. We essentially shifted the narrative from most patients don't screen to most patients do screen through culturally sensitive education. Now let me walk you through statistical analysis of what it means. The z-test statistic was 1.636 with p-value of 0.051. Using a significance level of 0.05 for one-tailed test, the critical value was 1.645. Our z-statistic of 1.636 did not quite exceed the critical value of 1.645, and the p-value 0.051 was just slightly above our alpha of 0.05. The 95% confidence interval for the difference in populations ranged from 0 minus 0.035 to 0.454. The fact that this interval includes 0 means we cannot rule out the possibility of no effect with 95% confidence. The achieved power of 0.497, essentially 50%, which indicate moderate statistical strength. What does this mean? Let me be transparent. The results did not reach conventional statistical significance by traditional standards. The p-value of 0.051 is so close to 0.05 that if we just had 1 or 2 more patients complete screening, we likely would have achieved significance. However, and this is critical, a 21% absolute improvement is clinically meaningful. In real-world clinical practice, improving screening adherence by 21% points represents substantial impact. The primary limitation was sample size. With 60 patients total, the study was underpowered to detect this effect size indefinitely. So while we cannot make definitive statistical claim, the clinical significance and the direction of effect strongly suggest that culturally sensitive interventions hold substantial promise for improving screening in this population. Let me be candid about the limitation of this project, because understanding limitation is essential for interpreting results appropriately. Sample size. With only 60 patients total, the study had limited statistical power. This is why we achieved a power of 0.497 rather than the ideal 0.80. Larger studies are needed for definitive conclusions. Single site. Conducting the project at one clinic limits general liability. Results may not apply to other settings, different geographic regions, or Vietnamese populations with different characteristics. Lack of control group. This was not randomized control trial. I cannot completely rule out confounding factors like seasonal variation, concurrent community health campaigns, or other provide encouragement that might have influenced the results. Short follow-up. The 6-month timeline may not capture long-term behavior changes. We don't know if patients will continue screening in subsequent years. Selection bias. Patients who are more engaged with their healthcare may have been more likely to complete screening regardless of intervention. Retrospective design. I rely on documentation's quality in the medical records, where it introduces possible measurement errors. These limitations don't invalidate the findings, they contextualize them and point the way for more rigorous future research. So how do these results relate to impact? Let me discuss 5 key points. Clinical impacts. The 21% improvement represent real patient completing life-saving screenings. Early detection prevents late-stage cancer, reduces mortality, and improves survival rates in vulnerable population. Every patient who gets screened has a better chance of surviving if cancer is found. Cultural competent works. These results confirm that literature suggests that culturally sensitive, linguistically appropriate education resonates with Vietnamese patients. When providers take the time to communicate in ways that respect cultural values and address cultural concern, trust builds and understanding deepens. That trust drives behavior changes. Health equity advancement. This project addresses screening disparity that promotes justice and equity in healthcare. Every percentage point improvement reduces health and equity. When we close gaps for underserved communities, we move closer to ethical ideal for everyone deserves equal access to life-saving preventative care. Feasibility for practice. This was a low-cost intervention that integrated seamlessly into routine clinical care. It didn't require extensive resources, expensive technology, or major outflow disruptions. This demonstrates that meaningful improvement in health equity don't always require massive investments. Sometimes they require cultural humility, language access, and taking the extra minute to communicate effectively. Need for larger studies. The statistical limitation underscores the importance of conducting larger multi-site research that adequately sample size to definitively establish effectiveness and guide policies. This project provides preliminary evidence and effect size estimates that can inform those larger studies. Implications for practice. What do these findings mean for practice, patients, and healthcare community? Impact on my practice. I will continue using culturally sensitive education and all of my Vietnamese American patients. I'm expanding this approach to other preventative screening like breast and cervical cancer screening. I'm training other providers in my clinic in these culturally competent techniques, and I'm documenting outcomes systematically to demonstrate value to clinic leadership and potentially secure resources for expansion. Impact on patients. Vietnamese American patients now have improved access to culturally appropriate health education. They experience enhanced trust in healthcare providers and the system. They benefit from earlier cancer detection and better health outcomes. The culturally grounded education reduces their anxiety and fear about screening. And most importantly, they feel empowered to inform health decisions because they truly understand what's being recommended and why. Impact on healthcare community. This project provides an evidence-based model for addressing health disparity that can be adapted to other minority populations, not just Vietnamese Americans, but other Asian subgroups, Hispanic community, African American populations, and any group facing culturally and linguistically barriers to care. It supports policy advocacy for culturally competent care by demonstrating that these interventions work. It shows that low-cost, high-impact interventions are feasible in real-world clinical settings, and it contributes to the growing literature on health equity and cancer screening. Let me summarize what this project accomplished. I implemented culturally sensitive education for Vietnamese Americans in primary care setting. I achieved a 21 percentage point increase in colorectal cancer screening adherence. I demonstrated clinical meaningfulness despite statistical limitation. I created a sustainable, replicable intervention model that other clinics can adapt, and I contributed evidence to health equity literature that will inform future research and practice. Impact made. This project improved screening rates for vulnerable population. It advanced cultural competence in my own practice and in my clinic. It provided preliminary evidence that support wider implementation of similar intervention. While statistical significance wasn't achieved, the clinical significance suggests this approach has real-world value. What I would do differently. If I were to do this again, I would recruit a larger sample size, minimum 100 patients per group, for adequate statistical power. I would include a control group for stronger causal inference. I would expand the follow-up period to at least 12 months to assess sustained behavioral change. I would add a qualitative component, perhaps interviews with patients to capture their perspectives and experiences. And I would partner with multiple clinical sites to enhance generalizability. Future plans. Looking ahead, I have both immediate next steps and long-term goal. I will sustain this intervention at my current clinic. It's now part of our standard practice. I'm training additional providers in cultural competence techniques. I'm extending this model to breast and cervical cancer screening for our Vietnamese patients. I'm developing printed materials in Vietnamese that patients can take home and share with family members. Long-term goals. I plan to collaborate with other clinics serving Vietnamese population to implement this intervention more broadly. I want to adapt this intervention for other Asian subgroups and minority population facing similar barriers, and I plan to advocate for policy level for funding that support culturally tailored care. Dissemination plan. I'm sharing these results with my clinic leadership and staff so they understand the value of this work. I'll present at local Vietnamese community health events to engage community directly. I'm creating a toolkit that other providers can use to replicate this intervention in their own settings. Before I conclude, I want to reflect briefly on how the DNP program has impacted me personally. The DNP program transformed me from clinician who focus on individual patients to a leader who sees system, populations, and an opportunity for change. I learned to identify problems rigorously, search evidence systematically, design intervention thoughtfully, and evaluate outcomes objectively. I now approach every patient encounter through the lens of cultural humility and health equity. I question why disparity exists and what I can do in each intervention and systematically to address them. I use evidence to guide my practice, and I measure outcomes to ensure I'm actually helping people. The program taught me to lead quality improvement initiatives, mentor other providers, advocate for policy changes, and contribute to the nursing profession through scholarships and dissemination. I feel prepared and excited to drive meaningful change in healthcare. This project deepened my passion for serving vulnerable populations. I've learned that cultural competence isn't nice to have. It is ethical imperative for effective, equitable care. I'm committed to being a voice for underserved communities throughout my career. Gratitude. I'm profoundly grateful to my faculty members, especially Dr. Berger, whose wisdom guided this journey, to my doctoral cohort and their support and friendship, and most important to my wife and 3 children whose sacrifice, encouragement, and pride in my work made this achievement possible. This degree is much as theirs as it is mine. Here are the references that inform this work, presented in the APA format. These slides document the evidence base that supported this project design and interpretation. That brings me to the end of my formal presentation. I want to thank you again for your time and your attention. This has been a meaningful journey. Thank you.